Hello, everybody. Thanks for coming. We'll just wait for a few more people to join before we get started. Just while we're waiting for other people to join, it'd be great if you could put in the chat, just on a scale of 1 to 5, how comfortable you are with the concept of human factors. You know, what do you know about it, and how do you feel in terms of thinking about it with regard to patient safety? So on a scale of 1 to 5, 1 being completely never even heard what human factors are, and 5 being somebody who's worked on projects and already considering human factors in design of systems or processes or equipment. So Sam is a 2, Claire is a 2, Emma a 3. That's good. So nobody with a 1. That's good. Julie is a 4. Most makes sense, but I keep getting confused with the language they use for different types of error. Yeah, me too. Me too, all the time. And yeah, to be honest, I think not most of the time it's not that useful to distinguish between the different types of error until you get down to the stage of designing a new process with better safety features in it. Then it might be helpful to think about the errors in terms of those different categories. Josh says 2. Good. Okay, we'll get started. So let me just not sure if I did that right. Yeah, let's do it this way. That's better. Okay, so the science of human factors. We're just going to learn about how human factors apply to healthcare, how changes to processes can mitigate the effects of the factors that contribute to error. We'll talk about simplification, standardization, constraints, forcing functions, and redundancies. And we'll discuss risk and benefits of using technology to improve patient safety. Okay. So why does human factors matter? Well, the World Healthcare Organization said healthcare workers who do not understand the basics of human factors are like infection control professionals who do not understand microbiology. So they're basically saying it's essential, but of course it's not something that a lot of people know about. Certainly it's not formally taught quite that often. Being aware of common types of cognitive errors can help clinicians recognize and avoid them. So we've been over this before earlier on in the course. So just a bit of revision because it is confusing, the difference between them all. So we classify them all as errors, but the errors can either be an action that did not go as intended, or the action was intended, but it was the wrong selection of action. So the decision making behind that was wrong. So if the action doesn't go as intended, that's either a slip or a lapse. You know, it's a error in execution. And when it goes as intended, but it's wrong, that's a mistake. So you chose the wrong thing to do, errors in decision making. And those mistakes can either be rule-based, so error in applying the knowledge correctly, or knowledge-based, basically stemming from a lack of knowledge. So moving on, we've got two types of mental processes that is really important to consider, is how we make our decisions, because that process inside that box of ours is prone to errors. That's where the errors happen. And there are two types of thinking that have different pros and cons. So automatic thinking is what some people call heuristics. And that's where you get a really rapid decision making. And sometimes you don't even know how you've come up with that sort of decision. You just kind of know it. It can be that rapid. It's a bit like riding a bike or driving a car. But it is prone to errors of execution. So there's a lot of corner cutting when it comes to heuristics or automatic thinking. There's a lot of shortcuts that are taken. And in doing so, that's where the errors happen. It's where gut feeling will come from. It's where pattern recognition comes from. So doctors diagnosing patients use a lot of heuristics. Is based on the patterns that they've seen in previous patients throughout their training and experience, and they apply that template to what they're looking in front of them. And those heuristics are 95% correct and 5% wrong, or roughly. So somebody with more skill will understand what type of thinking they're used when they're coming up with a diagnosis, and leave room for any assumptions. The opposite of that is controlled thinking, or it could be called slow thinking, which is a deliberate process where you try and slow yourself down and think through all the stages. And this can work when it comes to solving problems or making tough decisions. But this is prone to errors of planning, i.e. mistakes. So in order to think things out entirely and thoroughly, you need to have a plan that takes you through 100% of all the factors required to make that decision. And if you've planned to only look at 80% of all the factors involved, then you're going to disregard some of the data that's required to make an informed decision. And so because it's slow, we often are not good at planning out entirely what we need to consider. And also it's quite laborious process, even if you're just thinking on the fly, but more commonly, if you're thinking about a complicated problem or a project, that can be extremely complicated. So I'm going to give you 10 seconds to look at this. I want you to tell me what, on the chat, anything here you wouldn't drink. Your 10 seconds is almost up. So write in the chat something that you wouldn't have drunk from those pictures. Emma said Tide. Julie said baking soda. Sam said baking soda and cleaning liquid. Claire said juice. I suppose the juice doesn't look good either. Tide and baking soda. Okay, great. So maybe 10 seconds was not, it was too long for you guys. But the learning point from this is that Tide is put in a bottle that looks like cleaning product. It's got a very sort of non-tasty label. I would say. It doesn't look appetizing at all. It's got some bubbles on it, and it's in a big orange bottle with a funny lid. So you can instantly tell that you've never found any drink in the supermarket that comes in a bottle like that, with a lid like that, and with a design like that, probably. So you can very instantly recognize that's not juice. Everything else in the background is juice and apparently drinkable. But down here is baking soda, which quite a few of you spotted, which is great. But it's put in a jar with some writing like this. So first of all, it's in a jar which kind of you get some drinks in. It's got a picture of an apple on it, which might suggest that it's food. It's also got the color as well on it to make it look appetizing. And the word fabuloso actually doesn't mean much as to what's inside it. So if you only focused on the title, again, you might assume it was edible. So this is an example of a mismatch in signaling from the packaging compared to what's on the packet, what's inside it. So, and that's where heuristics. So if you only had like 10 seconds, or you guys are good, so maybe if I'd given you 2 seconds, you might not have spotted everything on this. You might have seen the tide, but not the baking soda. And that's the difference between fast thinking and slow thinking. So cognitive errors. So heuristics, mental shortcuts, are the way we simplify things. So an example, as I said, it would be a physician who assumes an unconscious patient's odor of alcohol is just another drunk, but they've missed actually that they're hypoglycemic, because they've not thought laterally. They've not considered all different differential diagnoses. So a pharmacist sort of grabs some medication, but it's not the right medication because it looks the same as another package. Or a nurse ignores a critical alarm because there are so many false alarms that the nurses have become desensitized. So that's alert fatigue, which probably people have heard about before. So questions to you guys. What factors make errors more likely to occur? So what do you think they're likely to occur in each of the scenarios? The physician diagnosing a patient, the pharmacist filling an order, and the nurse delivering the treatment. So think about what factors, so what things around that system will influence it to make it more error prone. Okay, think about automatic and controlled thinking involved in these tasks. So yeah, some suggestions on the chat, that would be great. Yeah, good, Sam. So interruptions. Yeah. Emma, staffing. Yeah, so I think what you're meaning the effect of poor staffing would be that people are overburdened. So they have what's called an increased cognitive load. And if the cognitive load is above the capacity of the individual, then there are lots of things that are going to get missed because there's not enough capacity to retain all that cognitive processing. Time pressure. Yeah, same thing. So pressure and stress can to a certain degree increase performance, but then it dips off quite a lot once you get too far. Sam, hard to access information. Yep. So making it difficult for information, and therefore you're just relying on your knowledge instead. Communication between parties involved. Yep, that's a good one, Josh. Access to information, we've had that again from Claire. Julie saying rare diagnosis or uncommon medication or treatment. So yeah, so unfamiliarity with a certain situation. And difficult to access information, again from Claire. Okay, yeah, so those are all great suggestions. Here's some other ones. So internal factors, which are psychological and physiological states. So we identified that being stress, being pressured, time pressure, or being given too much to do, fatigue, hunger, illness, attitude, memory. So then external factors, so these are environmental factors. So I think that would be more how much work you pile on somebody, noise, light, temperature, training rules or procedures, distractions or language barriers. So we communication between parties involve language barriers, same thing there. And then cognitive biases. So anchoring, confirmation bias, attribution error. This is probably the most difficult thing to really be aware of and control for, because most cognitive biases are fairly unconscious. So how can we prevent errors? So we can talk to our employees and say, you need to be better, you need to work harder, you need to be more vigilant. But we all know that that's probably not going to work, because it's difficult to get people to sustain performance above what they're naturally able to perform at. And so trying harder doesn't really work in the long term. So that's where human factors come in, and human factors engineering. So it strives to understand how people perform in these circumstances, and then build the environment and systems around them to limit the mistakes that are possible. And it takes principles from lots of disciplines. So, for example, in anesthesia, they really have come a long way in terms of safety. Having somebody die under anesthesia is extremely rare these days, whereas it actually used to be relatively risky in the old days, especially with chloroform and things like that. And when you went under the knife, people would say, am I going to survive? And some of those people would not wake up. Fortunately, that's just almost not a scenario that we have to deal with these days. And how did they achieve this improvement? Well, it was through a lot of systematic work, such as standardizing the equipment they use, so that, for example, turning the valves was all the same way, clockwise instead of counterclockwise, so that you wouldn't make a mistake of turning oxygen off when you meant to turn it on. And that has happened. Avoiding reliance on memory through checklists. So a lot of checklists to make sure the machine's working in the morning before they use it. Checklists in terms of preparing all the equipment for airway intubation, and making sure they got backups and plan B, etc. And then promoting teamwork by encouraging nurses and others to speak up. And this is the flat hierarchy idea, that if there's less of a barrier for people to speak up, then they may be able to offer alerts to problems and solutions to problems whilst they're required. So strategies to prevent error. Simplification would be one. And maybe in the chat, we could start to generate a list of other things that we can think of. So if you could put in the chat other strategies to prevent error. Emma, clear roles. Yep, so clear roles. And if you expand that a bit more, you're talking about protocols, basically, which clearly define who does what and when. Julie, avoid memory-based tasks. Yep, so checklists is one thing. Other ways to prompt people how to do stuff, such as automated things, for example. So you take it out entirely. You have timers and clocks. Standardize. Yep, standardize. So that's about protocolization. Getting people to do the same thing every time creates less error. So yeah, standardize is on there. Avoiding reliance on memory. Improve access to information. Taking advantage of habits and patterns. So one thing is in terms of habits and patterns, if you link things together, so like you do this and then you do that, and then you link the two actions together, now that becomes a habit of doing one directly after the other. So for example, when it comes to using a needle, as soon as you finished it, it goes in the sharps bin. And in order to make that happen, you need a sharps bin right there next to you. So if you can make that an absolute habit, then it comes automatic that it feels really alien to put that sharp anywhere else except the bin. And I've noticed this myself. If I'm on the ward and I've used a sharp, it feels really wrong to walk across the room with that sharp now. If I've forgotten my sharps bin, I just feel so vulnerable that I'm going to stick somebody with that needle, even though it's not going to happen. But just walking even across the room with a needle feels weird these days. So that's the habit gone in there. Forcing functions. So you can only do the right thing. So an example of forcing function in medicine was the very famous intrathecal vincristine problem that killed a patient in the NHS because they put the wrong chemotherapy intrathecally instead of intravenously. And now they've designed the connectors so it's impossible to connect the wrong chemotherapy to the intrathecal giving set, for example. So that's a forcing function. Visual controls, effective team functioning. So this goes around things such as simulation training, where you get to explore some of the team dynamics, that flat hierarchy, for example, how people perform under pressure, and learning about themselves, and learning about systems to stop that getting in the way. All those things can be taught in simulation. Redundancies. So redundancies would be a backup system. And we have lots of backup systems. For example, we've got MedChart running, but if that goes down, then we have all the paper-based systems ready to use instead. Eliminate external factors that degrade performance. So that's an example of that would be a nurse doing a drug round. One of the common reasons for errors is because they get interrupted all the time when they're trying to concentrate on putting the right pills in the thing. So one project, I don't know if it was that successful, but they gave the nurses these bright fluorescent tabards to wear that says, "Do not interrupt me." And I think it might have worked in pilots, but in practice it didn't work because the nurses didn't like wearing them because they made them feel stupid. So I've not seen them used here, but certainly that was an attempt to reduce interruptions on drug rounds. Create systems that are better able to tolerate errors. So that's just giving more room for error, a bigger margin for error. So there's 5 examples here. And maybe if you could just put in the chat your answer to 1, 2, 3, 4, 5 in terms of what strategy is being used here in terms of trying to reduce error. So double checking someone's work. What sort of category of strategy is that? And then do the rest. So 2, 3, 4, 5 there. That would be good on the chat. Okay. Sam says, first one is redundancy, second one redundancy, third one simplifying, then standardizing, then forcing. And Julie is fairly similar, except 4 is pattern recognition and redundancy, the last one. So let's see what they think. So yeah, first one is redundancy. Second one, building systems that can tolerate errors. So yeah, I think I agree with you. I think it's probably also an example of redundancy, because you would think that the person might spot the potential error before a computer, or as well as a computer. So I think that's probably redundancy as well. Simplification for the third one. Third one is taking advantage of patterns. So Julie, yeah, you said pattern recognition there, for example. And last one was a forcing function. Okay, good. So technology. So we often think of a technological solution to a problem, and there's nothing wrong with that. But the problem is that technology always needs a human to operate it. And there's always an interface between humans and technology. So what really needs to be considered first is the system, and then how technology will fit into that, rather than thinking, oh, we've got this technology, how do we fit it into our existing system? So, you know, examples of technology helping would be like electronic medical records, so we don't lose notes, etc. Barcoding, so that we have less errors in copying numbers, like hospital numbers, for example. Computerized prescription order entry systems, i.e. MedChart, intravenous infusion pumps, instead of just hanging a drip up. And they solve, often technology will solve one problem and create another one. So the electronic medical record solves a lot of issues in terms of access to the records, or lost records, for example. But they create another problem. They create problems in terms of if the computer system goes down, we don't have a readily available redundancy system. I mean, we have the paper records, but they're out of date because they're no longer being kept up to date efficiently with all the information that we put into the computer. So it's actually a major incident if the medical records go down, such as it happened in Waikato when they got hacked. And not only did they go down, but they didn't come back online for several days, I think it was. And when you're so reliant on an electronic medical record system, when it goes down, almost nothing can be done in terms of patient treatment. It's that fundamental. So then you've got to think about ways to make medical records bomb-proof. And of course, in Waikato, that showed that we have a vulnerability there. Computerized prescribing systems. So, of course, yeah, the system goes down. That's another problem. But actually, another problem with that is that it makes the medication chart less accessible. So now you have to be able to view it on a device. And when doctors and nurses are doing ward rounds at the foot of the patient bed, that device needs to be available and quick enough for us to pull up the record and review the medications whilst we're reviewing the patient. And here is the problem in Dunedin that, so anyway, in Dunedin, I don't know what's like in Southland, but certainly as soon as you push a computer into the wards, the Wi-Fi drops. So you can't review medications by the patient's bedside. And that is a safety issue. So we've taken one problem of a missing medical chart, and now we've replaced it with another one and was, oh, it's not missing, but you still can't use it. So those are examples of how technology is always a double-edged sword. Julie says, I actually think quite often physical records make information less available. The amount of times OBS charts or notes can't be found. Yeah, exactly. So I think, you know, technology has solved the issue to a certain extent, but it is not a panacea. It's not a silver bullet. It doesn't come with, it comes with other problems. But yeah, no, I agree. Paper medical records are less accessible. And I remember paper drug charts going missing, and that was a nightmare as well. Absolute nightmare. Best practices. So design processes. This is in terms of, you know, implementing technology into your systems. You need to design the processes to be effective first, and then use technology to simplify and standardize. So not the other way around. Don't come with a solution looking for a problem. First of all, find your problem, work out a solution, and then work out where the different bits of technology fit in that. And the technology should be tested in the real world situations by actual users. Workarounds can lead to serious error and should be viewed as symptoms of poorly designed systems. And users should not be overly reliant on technology to perform double checks, and still be able to perform double checks when reasonable. Sorry, as you probably can hear my dog in the background going nuts. So now we're gonna watch a video. I'm just gonna make sure we got the computer sound here.
Welcome. This is part 2 of our reliable design methodology. In part 1, we talked about why we have reliable processes and what we need to do to make them reliable. Now we're going to talk about the methodology and how you can begin to apply it in your processes. The first is to start small. That is, start with a subset of your population. We know that in all situations, the same process won't work for every patient. So we have to figure out which ones work best and how do we apply them in the context of the care that we're delivering. We also have to design the process that is the easiest to work with. That is, we don't want to add complexity to what the caregivers are doing every day. So we're going to simplify that process, make it as easy as possible to do the right thing. And ultimately, by starting small, you can learn about what works well in that population, because if you can't get it right in that population, what makes you think you can get it right in the rest of the population? So learning will help you grow and spread your processes to other populations. What is a subset or a segment? It should be a group of patients that are easy to identify. It should have willing participants on the part of the healthcare providers who are willing to work with you to test new methodologies, to test the way you want to design the process to make it more reliable. You can learn from that subset so that you can continue to expand and spread your work. And the subset has to have enough volume that you are able to test daily or every other day. And what we mean by that is that if you are not able to test daily and you can only test once a week, you can only learn once a week. If you run your tests daily, every other day, or even multiple times in the same day, each one of those is an opportunity to learn. And so you can move more quickly in your improvement processes. An example could be patients in one ICU, or it could be just Dr. Smith's patients, for example. Or it could be just patients in one clinic of a large clinic setting. Or it could be just male patients over 65 who are coming in for a particular screening. Those are all examples. Now your subset you have to examine, because if it's too large, then you need to narrow it down a little bit. If your subset crosses many areas of care, that is many clinics or many units, many wards, then that's going to be a challenge too, because each unit has its own culture and its own challenges. So you want to try to limit it to just one area. But just remember that it has to be volume large enough that you can test daily or at least every other day. The next step is to visualize the steps in your process. We ask you to draw a flow diagram of 3 to 5 boxes, no more than that. Some of you may be familiar with lean methodology or others that ask you to draw this very complex driver diagram, and there's nothing wrong with that, but it's really complicated, takes a lot of time, and we want you to visualize very quickly the 3 to 5 steps that are in your process. Now, the 3 to 5 steps may look different from one hospital to another or one ward to another, but it's conceptually what the process looks like for you and what needs to happen. And then within those, identify the defects. Now think of, is there a possible cascade? That is, if we don't do the first step right, it doesn't matter how much we make the other steps more reliable, we have to make the first step right. So let's take an example of what I mean. If we are developing reliable processes for managing a patient with a pressure ulcer, but we don't have a good, reliable process to assess the patient for pressure ulcer risk, then we can develop all those processes, but we don't know how to best to apply it because we haven't identified the patients for whom to apply it. In that case, the flow diagram would point out to you that the first step should be, let's make sure we have a reliable assessment process. You might also identify which is the biggest defect that we need to work on, because if we can fix that defect, maybe we can make the rest of the process much more reliable. And from there you can continue, because you will have to work on the other steps in the process as well. This is an example of a high-level flow diagram. This is a patient who needed to receive a vaccination, and the patient is identified. Again, there's an assessment done that the patient is eligible for the vaccine. Vaccine is prescribed, the vaccine is administered, it is documented, and then it is communicated with primary care, for example. In this case, this team identified that they failed to identify the patient who should be eligible for that vaccine. Therefore, they needed to start there to identify where they can make the process more reliable.
Great. So we're going to have a bit of discussion now about that and other things and to do with human factors. So when designing a reliable process or system, why does Frank recommend starting with a small test? So has anybody conducted a test and wish they'd made it smaller? So if there's anybody got something to share about that, please unmute yourself and share it with the group.
Oh, sorry. Can people hear me?
Yes, Sam. Thanks.
I don't know if I've ever wished it smaller, but I guess where you would wish it was smaller is if there was actually a fundamental problem that you needed to fix before then you could really test kind of the meat of it. So, for example, if you just made a simple mistake, maybe you'd wish you started smaller, because then you could have gone to one or two people and they immediately could have said, oh, well, that's not going to work because of this. And then you can actually fix that and then do the wider testing. Otherwise, your wider testing would be kind of compromised because people wouldn't really test beyond that obvious mistake. If that makes sense. They'll just say, oh, well, this isn't going to work. And you wouldn't get the feedback on the rest of it. That's the only thing I can think of there. I don't know if anyone else has any thoughts.
Yeah, I mean, I agree with that principle. It's good to share your work when it's in draft format and early, rather than trying to polish it and make it perfect. And then you've obviously not considered something important, and then you got to go back a bit. And if you've also done your testing with that assumption in place, then that also might put you back quite a bit. So yeah, sharing your work right at the beginning with people is really, really important. Josh said his audio doesn't work, but on the chat he says, I think Frank recommends testing small to trial a process and see what would work and what doesn't. I come from an engineering background and have definitely wishes I made some tests smaller. Okay, that's great to know. I often find myself that when it comes to getting some data, for example, it's always easy to think about just collecting data on everything, But that obviously takes a long time, and starting smaller for that means trying to find the smallest sort of sample that will make some meaning to you, and then help you with your project. And then starting small would be, really considering about what's the smallest unit that your project can work inside. Can it be one patient to begin with? And I guess I also got an example of when I did use that and it really worked well, was when I was trying to design a new pathway for day case abscess surgery. And I knew that actually we currently did about 5% of patients as a day case just by chance, because everything lined up. The patient came in, they were already starved, they had an abscess, there was nothing in theatre happening. So they went straight through to theatre, and then people said, well, they're going to wake up so quickly and go home, let's just put them through day surgery rather than admit them to the ward. And so it just happened by chance. And my first thing was just to say, okay, can we make this a bit more deliberate? Can we pick a patient in advance and actually do a day case pathway with them? So we did it with one patient. And you might think, well, that's not going to change anything. But it was really important because it brought a lot of people on board to the fact that it is something that's possible in our system at the moment. And I was able to take a little video of the patient being really happy afterwards and going home. And that message that was then broadcast out to all the people, all the stakeholders on the project, really sort of got behind that and made the rest of the project more successful. So I think starting with the smallest thing so you can guarantee some sort of success and be able to build some momentum for your project is really important. Julie says, small test requires less resources. So if it fails or needs modification, it's less of a big deal. Yeah. And people don't care as well. If it's a very small failure, then we don't care. But if it's a big project that's failed, then people will say, well, it just can't be done. And that's not what you want, because then you're just back at square one. So thinking of a daily process in work, what population is involved in that process? And if you wanted to make a change to the process, what subset of the population would you start with? So has anybody got any ideas for their areas?
That's a bit of a tricky one, really, isn't it? Because I guess it depends what you want. So in some ways, it'd be easier to start with the people who are more open to change, because then you can build a bit of momentum. But and from another point of view, starting with people who are not that big on change would give you perhaps a fairer test of how ultimately successful. So I don't know. Do you want to build momentum, or do you want kind of to really test the process by making it as hard as possible? I don't know.
So, I mean, I think in your area, Sam, where you're trying to control all these documents, we all know just how much is in Midas and how much of it is unread. So your total population would be the whole of Midas, which is extremely daunting. So can you think of a way to a subset of that population that would make your change process a bit easier?
Yes, no, absolutely. So yeah, you can break it up several different ways. You could break it up by what sort of documents people are accessing. So are we talking corporate? Are we talking medical? Are we talking nursing? Are we talking allied health? You could break it up by site. You could look at a particular site, say Dunedin versus Southland, because often there's very big differences. You can break it apart by service. You can break it apart by document controllers compared to just people trying to access the documents. Yeah, I guess it depends on what sort of process you're wanting to test. when we looked at the system upgrade as a whole, we did try and get a bit of a cross section of all those for that kind of reason, because we wanted to try and cover all those use cases. But yeah, I mean, there's particular areas who use stuff more heavily than others. So I guess there's areas that use, say, manuals quite heavily. So if you wanted to change manuals, or maybe look at doing away with manuals and replacing them, you would probably target those groups that already make heavy use of the manuals, such as infection prevention and control, for example. And they have actually largely moved away from the manual, funnily enough, although it still exists. Yeah, sorry, I don't know if it's helpful for anyone else, but yeah.
Yeah, no, it's good to think that out. So yeah, in my area, obviously the population is our patients, and patients, a really common presentation of patients is appendicitis. You know, a lot of people, 1 in 7 people will have appendicitis during their lifetime. And if we wanted to improve care for people with appendicitis, we could start collecting data on everybody who has appendicitis coming through the unit. And that would be quite laborious, quite a long job. But we probably don't need to do that. We could probably collect data on a consecutive 30 patients, for example, and that would give you probably a good data set to work from a point of view of quality improvement. So that's one way to sort of make your population subset small. Wire flow diagrams helpful in designing reliable processor system. What other visual tools do you know of that can help with process improvement? Emma says they're easy to follow. Yeah, so I mean, I think flow diagrams are great. They take time to do, but they're much better than just a list. There's something about having a visual cue that really gets into people's minds. Julie says, makes you think about each step. Yeah, so each step is visible. You might forget about some steps, and it also makes you think about what is the order of those steps and where to start in terms of your improvement process. And Josh says they help visualize the flow of a particular process. Absolutely. So, you know, I use flow diagrams quite a bit. I have used the lean method once or twice for creating a process control chart where you can actually calculate the value time, the lead time, and that way you can work out what the waste in the system would be. So it's really interesting to do a patient flow diagram, and underneath you put down how much value time in each step. So the value time would probably, from the patient's point of view, be mainly the contact time they have with the clinician or the nurse or something like that, because that's when they're receiving active care and advice. So typically a 10-minute consultation in clinic, for example. But what's the wait time? So they come, they sit, they wait, then they see. So that's probably about, can be up to an hour, plus the travel time as well. Yeah, if you want to factor that in, about half an hour. So for an hour and a half of lead time, they have 10 minutes of value time. If you compare that flow process to, say, an online consultation, there's no travel time. There's wait time, but the patient's waiting in their own environment, so it's not quite the same. So you might even call that not waiting time, especially if they don't need to, if they can carry on doing what they're doing at home. And then you've basically got the 10 minutes of value time. So now you've got a much higher ratio of value to dead time compared to the old model. So that's a great way of comparing two processes, for example, and actually showing the value of one process over another. So that brings us to the end of the discussion. Has anybody got any other sort of experiences to add, or opinions they have in terms of human factors, or any stories they'd like to share?
Oh, sorry, James. Just going to say, just in the chat there, just above Emma's comment, easy to follow. Sorry, is it Julie?
Yeah.
Had a comment.
Oh yeah, as a house officer on orthopedics, we had some trouble with handing over patients who came in overnight as house officers, are not necessarily also orthopedic. So she'd start with ortho and night house officers, trying to come up with better handover system, and maybe see if it can spread to other surgical specialties. That's right, Julie. And I think, you might even start even smaller to begin with. So you might even say, okay, we're going to trial a new handover system for ortho and night house officers for one night, and then we're going to talk about it afterwards. So if it doesn't work, it doesn't matter, because we're not going to do it the next night. And if it does work, then we're going to talk about it and probably try and do it some more, rather than trying to convince them right from the beginning to change and never come back. So yeah, just doing it for one night, I think, would be the smallest unit of change that you could probably do there. I don't know if you've got any other opinions on that one.
James, so it's not an opinion on that, but I just wanted to say, just working in a lot of kind of emergency situations, that's often when kind of errors happen, because things have gone a bit crazy, or it's the middle of the night. I personally find, and I don't know about anybody else if they've been involved, is having a debrief, like once the emergency's over and everything's over, or things might have turned out fine, but there were things you probably could have done better, that it might have avoided less confusion. Having a debrief with the whole team involved and people that weren't involved is quite helpful, because then everyone has their own lens on what went wrong, what went well, what could be improved. I find those quite helpful.
Yeah, I do as well. If you compare that to a simulation where you're controlling the learning, the most important part of the simulation is the debrief afterwards, because that's where you get some insights into your own biases, and you can come away with some personal learning points. So yeah, a debrief is really important.
Yeah, I find simulations, I don't know, everyone's just a bit more awkward because it's not real, and you can simulate as much as you want, but it can never replace the real thing.
Exactly. So if you got the real thing, you need to really capitalize on the learning as well. Absolutely. Yeah.
Not that I wish for the real thing.
No. Julie just added, debriefs are an amazing way of learning for junior staff and help me understand what other people were doing, and will help me should a similar situation arise in future. Yep, absolutely. Unfortunately, it's not a common thing that we do, because everybody kind of finishes and go, oh, thank God for that, and rushes off back to what they were doing before. But I think, if there's some leadership at any of these crisis situations saying, okay, can we just all sit down and take 5 minutes to debrief? And I guess the other problem sometimes is that if a certain crisis has been so emotive, then the debrief is really not a learning debrief. It's just a strategy for actually returning people safely to the workspace in terms of their emotional and psychological stress, which is important as well. But it's a different objective, that sort of debrief, compared to a sort of debrief for learning. And yeah, Emma, says sometimes the next day is better. Yeah. So sometimes you need a bit of a breather, and then come back and then have a more cold hard think, rather than while the emotions are flying. Right, well, it's 5 to 1, and it's a lovely sunny day, so I hope you guys might get some lunch in the sunshine, or be able to enjoy it after work. Thanks very much for your time. Cheerio, bye. And the dog gets a walk. He had one this morning.